So we're going to start right on time. Thank you all so much for being here, especially at this late in the conference and this late in the day. It's wonderful to see all of you here. My name is Rose Wilcher. I'm with FHI 360 and the USAID and PEPFAR-funded EpiC project. And we are really happy to be here co-hosting this session on the Key Populations Investment Fund with our friends from MPact and the Johns Hopkins University. So for those of you in the room who might not know what the Key Populations Investment Fund, or KPIF, is, it was a significant $100 million investment from PEPFAR to bolster the HIV response for key populations. It was meant to strengthen service delivery uptake among key population community members, to provide funding to and strengthen the capacity of local KP-led civil society organizations, and to really rectify the persistent shortage of funding for key population communities to address structural and legal barriers that really keep epidemic control out of reach for many KP communities. KPIF programming started in about 2019 and recently ended in most of the countries where it was invested. So here we are in Montreal, fresh off the two-year implementation period of this significant investment. And it's an opportunity for us to take stock of what happened and really what the value of this dedicated key populations investment was. So we're going to explore during this session, what impact did it have on service delivery, on local partner capacity, and most importantly, on the community members it was intended to serve. So we have a really great lineup of speakers, and throughout the session, we're going to hear from partners who were directly involved in either implementing or evaluating KPIF, including representatives from local CSOs who received KPIF funding. So I'm going to turn it over first to Timothy Ma. So Tim, let me get my notes. Tim currently serves as the acting deputy director of USAID's Office of HIV/AIDS. He joined USAID in 2008 and has served in numerous positions, including division chief of the Strategic Information, Evaluation, and Informatics Division, and the deputy division chief for the Priority Populations Integration and Rights Division. And Tim is going to get the session started by really talking about what KPIF is and how it came to be. And you can... There you go. So you can just do arrow down.
Great. Good evening, everyone. Great. So yeah, I just wanted to provide some introductory remarks. So first, thanks for joining, as Rose said, at this late hour and this late day of the conference. So really glad to have people here. I'm really excited to really reflect on what we've been hearing, some of the key themes over the past few days. First, just to start, we've heard themes on meaningful participation, inequalities, sustainability of the HIV response, and of course, following the data and the science. So in this slide, you see, of course, global and country data continue to point to the fact that we need to do more for and with key populations. So in 2019, the Key Populations Investment Fund was established by PEPFAR, and it was an additional $100 million to really strengthen the response and to better meet the needs of various key populations and communities. So this additional funding was the result of really following the data and also intense advocacy from many people across different key population communities. And this is really important, again, to make sure that we're really involving everyone that we were hoping to engage with. Within the PEPFAR family, USAID programmed about $50 million of the $100 million, and we did this across 21 countries and across 2 regional programs as well, or platforms. And while there are many things that we could have done better and differently with the Key Population Investment Fund, we know that the work accomplished many incredible things over the 2 years. So for instance, through USAID and through the Key Populations Investment Fund, there was work that happened in 10 different countries to advance supportive policies for key populations. And through EpiC, we worked with 99 local CSOs, community, civil society organizations in over 20 countries. And importantly, many of our advances in programming for transgender populations on the continent of Africa occurred because of the Key Populations Investment Fund. So I won't take up any more time, but I'm really excited to hear from the panelists about reflections about how what we did well, what we didn't do well, and how we can learn from the experience to do better in the future. Thanks.
Let's see. Thank you, Tim. Okay. All right, so now we're going to hear from Hallie Mahler. Hallie is FHI 360's HIV director and also the director of the EpiC project, which has a global footprint in more than 40 countries. And as you'll hear from Hallie, EpiC was one of the projects that received some of the KPIF funds and a project through which it made its way to local CSO partners. So Hallie's going to talk at a sort of high level about what impact KPIF had across the 20 countries in which EpiC programmed KPIF funds.
Hi, everybody. Good evening. I'm so glad to have you all here with us. So thanks for the introduction, Rose. Not clicking. I have no relevant things to disclose. So EpiC. The EpiC project is a 5-year global award. It's PEPFAR and USAID funded, and it was designed originally to provide direct service delivery and mostly technical assistance to achieve HIV epidemic control and promote self-reliant management of national programs. It's led by FHI 360, and we have several core partners, Right to Care, Palladium, and PSI. It was designed as an HIV project, but it was actually in 2020 modified for also COVID-19 work. And I think what's interesting is, as we were modified, it's also the same period of time during which the KPIF program was being implemented, because many of the results you're going to see today happened during COVID, and some of the greatest adaptations that came through KPIF were as a result of having to modify programs due to COVID. So currently EpiC is actually implementing HIV and COVID programs in 55 countries, about 33 of which are HIV specifically. And we have about 200 local partners. So as you heard from previous speakers, KPIF was a global $100 million investment from PEPFAR to increase access to and retention of high-quality HIV prevention and treatment for sex workers, men who have sex with men, transgender individuals, and people who inject drugs. And EpiC is one of several projects that was asked to administer the funding for KPIF. The core elements of KPIF included increasing KP testing coverage and case finding, scaling PrEP through community and facility service delivery models, enrolling more KP in treatment, retaining them in treatment, and viral load suppression, also addressing specific structural barriers that inhibit access to and effectiveness of services, scaling U=U, strengthening KP indigenous organizations, and of course monitoring the results in real time because we're talking PEPFAR. And actually a total of almost $40 million in KPIF funding was programmed through EpiC. And with that funding, 99 community-based organizations across 20 countries in sub-Saharan Africa and Southeast Asia received funding. These are the countries that received funding. You can see there are countries that received direct funding, and there were also countries that benefited from regional technical assistance. And we're going to talk a little bit more about that regional technical assistance later. So these are some of the high-level results from KPIF. I think, 172,000 more people tested, 18,000, almost 19,000 newly diagnosed, more than 20,000 initiated on treatment because there was also return to care. There's more than 25,000 people initiated on PrEP during this time. And as you can see, the disaggregated tested numbers by different types of populations here. The majority of folks who benefited from KPIF were men who have sex with men, female sex workers, and PWID, but there's also transgender work that was scaled up in some countries and a variety of other populations. Oops, keep pressing the wrong thing. There we go. So KPIF, the numbers that I just gave you, they were numbers on top of programs that already had COP targets. So these were additive, and you can see in the slide what those additive numbers looked like. It represented about a quarter, a little less in some cases, of additional targets in countries that received the funding. So what were some of the big KPIF contributions to transgender programming? Because this was one of the explicit areas in which we were asked to work. So with KPIF funding, transgender programs were supported in Myanmar, Cote d'Ivoire, Laos, Malawi, Namibia, Nepal, Nigeria, Philippines, Thailand, and Togo, and resulted in about 12,000 transgender people testing for HIV, about 1,500 newly diagnosed, with a case finding rate of about 12.6%. New people on ART, and the virally suppressed number, is not exactly 100% the full cohort because we're still following them through the main program. Not everybody was eligible for viral load during the course of the KPIF implementation. We created strategies our CSO partners, I should say, created strategies to mobilize transgender communities, empower individuals as community-based providers, engaged with law enforcement and healthcare providers to reduce rights violations. And one of the things that's most exciting is the first transgender-focused clinic was opened in Myanmar, and a transgender clinic in Kathmandu was strengthened. Another explicit area of contribution for KPIF was to help scale up PrEP. This coincided with a major scale-up effort that PEPFAR was undergoing at the time. So through KPIF funding, it enabled an expansion of PrEP programming in Cote d'Ivoire, Ghana, Haiti, Lesotho, Namibia, Nigeria, South Africa, and Thailand. This included, there was and still is a lot of work to do on PrEP on the policy side, supporting policy development, demand generation, and rollout, particularly of KP-led, demedicalized PrEP service delivery models. It resulted in more than 25,000 new PrEP clients, with local partners exceeding PrEP targets in many countries. And one of the things that you're going to hear more about today is how Thailand-based partners provided peer-to-peer technical assistance to their colleagues in Myanmar, Laos, and the Philippines to strengthen PrEP service delivery. Structural interventions was another important component of KPIF. These structural interventions were integrated into KPIF program and focused on critical enablers for HIV service delivery and uptake. They included reviewing laws, policies, and practices that impede uptake of services, reducing stigma and discrimination, interventions that help to prevent violence, bolstering social protections, and empowering KP communities. One piece of the structural intervention work was through a small grant program that was run by MPact Global Action for Gay Men's Health and Rights. They awarded an additional set of 19 local KP-led organization community engagement grants to strengthen their capacity, expand services, coordinate with other KP and allied organizations, and strengthen advocates. These were 9 to 12-month grants, and they were mostly organizations that actually we wouldn't have been able to fund directly because they might not be registered fully in country, for example. It was an effort to really try to reach organizations that oftentimes were not able to fund directly. And so organizations in Cote d'Ivoire, Malawi, Eswatini, Kenya, Mozambique, Namibia, Nigeria, and Zimbabwe received these grants. A highlight of some of the structural interventions was the work that happened in Kenya. In Kenya, there was increased awareness of issues affecting KPs through sensitization dialogues with 463 law enforcement officers and 110 religious leaders. 362 peer educators were trained on human rights advocacy, and trained as paralegals to help provide legal support to KPs in their communities who may need it. They reached about 1,800 peers with mental health services and support groups. They strengthened crisis response teams through peer training and establishment of hotlines, and they expanded access to alternative dispute resolution for female sex workers experiencing violence. And all of this together led to an increase in number of gender-based violence cases reported. Some of the local partner capacity building work was to provide tailored capacity building for each community engagement grantee following a rapid needs assessment and prioritization exercise, and also to ensure that community advocates were engaged and KP priorities were considered in COP and ROP planning. So MPact put out a series of briefs to support the KP community in countries and their engagement in the COP process, and I think we'll probably hear a little bit more about that later. And then the other thing that I've alluded to, and you're going to hear more about, which is using strong regional partners, particularly in Asia and West Africa, to share innovations and strengthen capacity through peer-to-peer organizational mentoring. One local partner highlight I mentioned, which is IHRI, the Institute of HIV Research and Innovation in Thailand. They provided capacity building to LPK, which is an NGO in Myanmar with significant KP leadership, to establish the first transgender-led clinic in Yangon. Mabaidar, opened in January 2021, and in the period of the project, tested 318 transgender women with a case-finding rate of about 16%, and initiated 61 people on PrEP. This work continues beyond the KPIF period. It did not end with KPIF. We worked with our local partners and our international partners to produce quite a number of resources that are available. If you go to fhi360.org/EpiC, and you can find all of these KPIF resources. These are just some examples. Case studies of work that was done in Kenya, for example, laying out the structural interventions work, how pre-exposure prophylaxis policy and program was initiated and scaled up in Ghana, how the capacity building and strengthening of regional networks happened in West Africa. There's many more materials if you go ahead and take a look at the website. So that's it. Thank you so much, everybody.
Great, thank you so much, Hallie. So Hallie mentioned that one of the really neat things about KPIF was that it positioned some local partners who have really been longtime leaders in KP programming as technical assistance providers to other more nascent KP-led organizations. And so our next two presentations are going to talk a bit more in depth about these regional technical assistance efforts. So first we're going to hear from Rina Janamnuaisuk. Close? Okay. She works as a program manager at the Institute of HIV Research and Innovation in Bangkok, Thailand, where she established Tangerine Clinic, which is the first transgender-led health clinic in the region. Rina. You're welcome. There you go.
Thank you very much, Rose, for the introduction, and it's a pleasure to see you again. And I would like to thank the organizer for giving me this opportunity to speak. So my today's presentation will be focusing around Asia Regional Key Population Investment Fund Technical Assistance, which is a South-to-South capacity strengthening on HIV testing, PrEP, and transgender competent care. And here's my conflict of interest disclosure. So working at the Institute of HIV Research and Innovation, or IHRI, under the KPIF EpiC project, we were responsible for strengthening the technical capacity of healthcare providers and community-based organizations in the region in the following areas. The first one is differentiated service delivery for PrEP, integration of transgender competent care into HIV services and programming, advancing telehealth, HIV self-testing, and self-sampling for other sexually transmitted infection, especially chlamydia and gonorrhea. And the next area is implementation of same-day antiretroviral treatment or same-day ART initiation for key populations. And the last component is to institutionalizing and sustaining the key population-led health services or KPLHS delivery model in the region. And the participating countries for technical assistance in the past 1.5 years under the KPIF funds, including Laos, Myanmar, Nepal, and the Philippines. So in terms of area of technical assistance provided by IHRI to other EpiC countries in the regions, you can see that we have 4 countries listed here, including the technical assistance area provided. So all of the countries in the list here, we are working together to strengthen PrEP capacity, transgender competent care. In terms of Myanmar, we're also working with them to strengthen telehealth and express services, including self-sampling for chlamydia and gonorrhea and mental health services. And we are anticipating that in the next fiscal year, if the funding allows, we are aiming to advocate for the key population-led health services model and certification and accreditation of this service model as well. And HIV self-testing, viral hepatitis C, and the package of chemsex services need to be addressed throughout the region as well. So these are the implementation strategies or technical assistance approaches that IHRI used in the 1.5 years under the KPIF funding. As we all know that the KPIF funding was approved right after the COVID-19 came, especially in Thailand. We were not able to travel in person as a team to meet with our local organization or with the government officials or even the other FHI country office in the country. So we have only one country that we were able to conduct a scoping visit, which was in Nepal. It was actually taken place just 1 month before the COVID-19 came to the region. And and the rest, we just only conducted virtual technical assistance platform, and we used mostly Zoom call to engage our clients, communities, and it started with identifying early adopters or creating learning collaboratives between IHRI and also the TA country recipients. And here, as mentioned earlier by Harley, I think one of the thing that we are very proud at IHRI is we are working together with the community-based organization and transgender community in Myanmar to establish the first transgender clinic in the country. So you can see that this slide shows you the before and after pictures. So all the technical assistance were actually conducted through Zoom or through mobile phone application. We actually used the mobile phone, Facebook Messenger to conduct a video call to show them how the Tangerine Clinic looks like in Thailand and how they're going to establish another transgender health clinic in Myanmar. So this is some of the photo that was actually came from the transgender community as well as with the Lanpajel Association, who the pioneer in establishing this Mabeda clinic. And in addition to that, under the Asia Regional KPIF project, we are able to expand the transgender competent care to other countries in the region as well. And this is not only limited under the EpiC country partners. You can see that we're working closely with the Philippines to integrate transgender competent care in Myanmar, Nepal, and also we have working together with other different funding mechanisms. For example, we work closely with USAID PEPFAR, Healthy Markets, and STEP projects to expand the transgender competent care. And we're also working with Sri Lanka under the Global Fund SKPA project to strengthen the capacity of the transgender community to provide a service for transgender populations. And here are some of the outputs and outcomes from the Asia Regional KPIF technical assistance activities. So far, we conducted 8 trainings on transgender competent care and PrEP services for community members and healthcare providers. So far, we have almost 400 people from 26 organizations trained. And we have also conducted separate 12 small group follow-up sessions with the country partners as well. And 2 transgender clinics were newly established in Myanmar. So the second clinic was the Daisy Clinic, which was located in Mandalay. We also developed 2 online modules around transgender health and the HIV counseling and testing for lay providers. We also developed a handbook on transgender healthcare services, which was the first transgender handbook available in Asia region in English version. And we had an opportunity to organize the first Asian Professional Association for Transgender Health Conference, which we have around 600 delegates attended virtually across 20 countries in the region as well. And in terms of program outputs, we have observed increased HIV case finding rate range from 2 to 15%, as well as increased PrEP uptake, which was ranged from 20 to 27% from the EpiC country partners. And in addition to that, our PrEP in the City program, which was the first regional PrEP, which is focusing on transgender women in Thailand, it was replicated and translated to Vietnamese and Chinese as well. So here are some challenges. We have 2 different levels. So the first system level in implementing the activities under the KPIF fund is that we actually receive unclear communications on priorities, which has led to the delay in planning and regional TA activities. We have also experienced delay in funding approval. It is also actually prevented timely implementation and procurement. So we all know that the KPIF project was 2 years, but actually IHRI receiving the funding to implement the project only 1.5 years. So we were not able to deliver as planned. In terms of implementation level, we found that when providing technical assistance virtually, we found that the lack of robust internet capacity and technological devices or handset in order to actively involve with the in virtual training, especially among the community members. When we conducted a training, for example, we asked all the community members to come together, but we have different sessions for them to conduct pre-test or post-test evaluation, but they cannot have their own devices, so that's why we were not able to evaluate or ensure that they will receive the technical assistance from the TA provider effectively. So, and another thing is that reporting system and indicators were not well established among FSI 360 TA provider and TA recipients, so that we did not know the end of the project, that what and how we wanted to deliver and meet the target. So I think this causing quite of confusion among all the stakeholders, and it needs to be addressed for the next funding procurement. In terms of opportunities moving forward, I would encourage to invest more in the interactive online technical assistance platform, since it may be more sustainable as well. And another one is to extend performance period and ensure a timely rollout for the potential successor program to KPIF. And I think it's very promising to sustain South-to-South region or intra-regional technical assistance collaboration. Strengthen technical capacity of the local expert to provide direct ongoing support to TA recipient is also another way to go in the region. And the last one, as I mentioned earlier, is to set the program indicators among TA recipients, local and regional TA providers at the beginning to ensure we mutually understand the tangible outputs for participating countries as well. And I would like to acknowledge all the support from PEPFAR, USAID, FSI 360, and all the community organization partners who contributed to the success of the program. Thank you very much for listening. Thank you.
Thank you, Rena. Always impressive and always learning from IHRI. Okay, there's something happening up here with the slides. Gonna need a little technical assistance. I'm going to introduce the next presenter while they work on the slide situation. So we're going to move from Asia to West Africa. And our next presenter is Nisali Turpin. She is with Endosante, based in Senegal, where she manages a large portfolio of regional projects financed by the Global Fund and USAID, among others. And she provides organizational and technical capacity development support to organizations throughout West and Central Africa. So we'll hear more about some of that work specifically funded by KPIF. Oh, and here we are. We're back up and running.
Good afternoon, everyone. Thank you, Rose. My name is Giseli Turpin. I'm the Deputy Director of Enda Santé based in Dakar, Senegal. I would also like to acknowledge my colleagues who also worked on this presentation. Her name is Fatou Ndao, and she serves as Program Manager for the Civil Society Institute for HIV and Health. So today I want to focus on what the EpiC and KPIF project created in terms of opportunities in our region. So I'm going to share a bit of experiences and lessons learned from TA provision in West Africa. This is my disclosure, okay. So a bit of a background. The Civil Society Institute for Health and HIV is a regional coordination and collaboration mechanism for civil society organizations working on HIV and health. It currently has 140 organizations members across 21 countries. It is currently hosted by Enda Santé Senegal, which is an NGO based in Dakar, Senegal. Our role in the EpiC KPIF project was to provide technical assistance to institutionalize health and HIV services for KP in government and CSOs at the local, national, and regional levels in the 6 project countries. Our objectives under this grant was to support KP champions and allies to influence the development of national HIV responses, to develop regional advocacy capacities that enable engagement and leadership of civil society organizations, as well as establish a response and advocacy mechanism to support timely and relevant KP advocacy and mitigation activities. Here, I just wanted to present to you a framework that we've been using for the past months and that we think should be used and could guide our intervention moving forward. First, what we feel is important is to reanalyze the current environment in our region due to recent events in several West and Central Africa countries that are undermining the fragile HIV and health gains achieved for KP to date. Then we need to rethink some of the core assumptions behind HIV and KP programming, taking into account the likely long-term trends in funding, as well as prevailing social and political attitudes. And lastly, we need to redefine approaches and programs for KP by focusing on support from within the country and region, as well as establishing endogenous positions and views to avoid automatic assumptions of foreign agendas. Coming back to the objectives of this grant, the first one was to support KP champions and allies. This created an opportunity for KP from Ghana, Mali, Togo, and Senegal to discuss new approaches and promote African-led initiatives. Lawyers from Ghana and Mali discussed laws and policies that create barriers to accessing HIV services. But they also discussed on current practices for addressing human rights violations. What we noted here is that we had 2 countries with different legal contexts. Ghana has specific laws addressing KPs, which is not the case for Ghana, but what was really surprising is that there are really similar issues faced in terms of access to health services, but also violations of their basic human rights. The second objective focused on developing regional advocacy strategy capacities. The webinar that we organized under this objective provided an opportunity for countries to build consensus on priority areas for advocacy based on examples of existing advocacy strategies. Some key recommendations included promotion of advocacy strategies at the regional level to push issues at the country level, setup of a pool of key population-friendly religious leaders, documentation and sharing of advocacy and success stories, and as well as developing thematic advocacy tools and materials. The last objective was on establishing a response and advocacy mechanism. We were able to develop a rapid disbursement mechanism to allow beneficiaries to participate in advocacy events, but also in trainings. and also providing them financial support to key population actors facing human rights violations. The eligibility was based on the organization being a nonprofit, community-based. They had to be present in one of the EpiC project countries, and also they would have to be active in HIV, gender, and human rights-related thematic areas. However, we've experienced quite some challenges in this regard as we promoted the availability of this disbursement mechanism, but unfortunately, no organization was able to follow through the process and access this funding. In terms of conclusion, and I would say that this to me is the most important part, is that the EpiC KPIF West Africa Regional Project provided us a safe platform and opportunities for dialogue between CSOs aimed at redefining approaches and programs for key populations. It also provided an opportunity for South-to-South experience sharing to promote African community-led HIV responses that ensure reach of all populations. It also created the opportunity to network between stakeholders who have an interest in progressive change and human rights. Some acknowledgements. We would like to extend our warmest regards to PEPFAR and USAID for funding the EpiC KPIF project. To FHI 360, namely Tiffany Lilly, Hélène Rodriguez, but also Fatoussi for their continuous support, as well as partners in the project countries. Thank you.
Okay, so our presenters so far have talked about what KPIF is and what its implementation has looked like across several different countries. What you may not know is that there was also a rigorous evaluation of KPIF. And so for those of you who have been waiting for the more scientific presentation with lots of data, now's your moment. So I'm happy to introduce Steph Barral. He is the director of the Key Populations Program at the Center for Public Health and Human Rights and a professor in the Department of Epidemiology at Johns Hopkins School of Public Health.
Thank you so much, everybody, for joining. As Rose mentioned, so I'm here to talk a little bit about this evaluation that we've been involved with and really trying to understand the impact of this KPIF programming. And I'm only going to really talk about 3 countries here in terms of Nigeria, South Africa, and Malawi. There's been a separate process really working closely with RINA and partners at IHRI focused on Asia, but unfortunately, we don't have time tonight. I have no relevant financial relationships with any pharmaceutical companies. So just in terms of, background, I don't have a lot of time, and I really want to try to say as much as I can, and so I'll provide a little bit of background and context. I think we've already heard a fair bit about KPIF, and maybe we'll hear more from others about how it changed over the years from how it was intended to how it came to be. I'll talk a little bit about the methods in terms of a global approach, but also the country-specific approach, which was really dependent on the data that we had access to, some of the results, and then some thoughts about moving forward. So I think, KPIF, the way it ultimately came to be, really supported a lot of service delivery innovations across the cascade. We've heard about some of those already from Ngisili and Rina and others. There was also a focus on structural interventions, and those really varied by country. But sort of an overarching element around KP sensitization dialogues, community-led monitoring. There was trainings around violence mitigation, human rights advocacy. There was capacity development, which was really, I think, core to the goal of KPIF, which was about capacity development, particularly in KP-led community groups. So looking at ensuring that they were better supported to lead implementation of these programs themselves, and as we've heard about, really facilitate this sort of learning independent of people like some of us. And then really policy development. And so ensuring that key populations are better represented in the national policy documents, and then also working on particular interventions like PrEP, self-testing, and certain HIV and STI programming. So our goal of this objectives was to work really closely with government missions, and I see some of the folks in the audience, which is great, key population stakeholders and implementing partners to understand what was the additive value of KPIF separate from the broader sort of COP process that was underway. And there were sort of 2 main sort of sub-objectives there. One was to assess the sort of impact of these programs, but also to really look at this heterogeneity, or like why the programs were working better for some populations in some settings and less so for other populations. And what does that mean for program design and implementation and the sort of adaptations needed by population and by geography in the future. So our focus was on using available data. We didn't plan this as any sort of trial or any additional data collection. We really needed to work with the existing data that were being collected by partners around the world. And we used a series of observational, quasi-experimental, or implementation designs. And we sort of had two main approaches depending on what data were available. One, we compared against historical data before KPF was implemented in each region, or we compared across geography. So within a country, if KPF was only implementing in some sub-districts, we would focus on comparing those against places where KPF was not working, but where there was a broader KP program in place. And I think we've heard this, and I think we all know this because COVID has affected every part of our lives. KPF really was implemented in the COVID era. And really, while it started in 2019, a lot of countries went into the field in like January of 2020, and COVID hit right away. And so it was methodologically complex to try to tease out what have been the COVID effects of decreasing programs across the board, and these adaptations that partners really did, I would say, heroically in order to react and continue to serve their communities. But there's also just this recognition that COVID universally impacted a lot of these programs, and we just kind of have to understand that. So in terms of looking at each country, what we did first were work with all the partners to really map all the different interventions that took place. And in Nigeria, there was a real focus at the structural level on strengthened peer navigation, which we will see is universal across all three of these countries. But there, a real focus on community-based support and a lot more online and social media engagement. They had the same PrEP outcomes in terms of initiation right through to retention, and then HIV testing and treatment outcomes. In South Africa, there was a Peer Navigation Plus program, and then there was the use of community engagement and safe spaces, and similarly the PrEP and testing and treatment outcomes. And then finally in Malawi, similarly peer navigation, but also these community outposts and drop-in centers, and then their PrEP and treatment outcomes. The data varied by country. And in Nigeria, we had access to site-level data that were extracted from InfoLink, which included the MER indicators that were either reported monthly or quarterly. There we had data from January 2020, so just a few months sort of before COVID started. We also had some individual level data from mainly in paper. It was cross-sectional, but it included some viral suppression outcomes and some basic characteristics in terms of gender, age, and key population. In South Africa, we really couldn't use individual level data because of the POPI Act, which is sort of a Protection of Personal Information Act. So we used site level data working with ANOVA and OUT that were extracted monthly or available monthly or quarterly. But there, at least we had data from January 2019, so we had historical data to compare against. And then we worked with BITS RHI that provided site level data for sex workers and trans communities. And luckily, older data there really starting in 2017, although also for some communities, including trans communities, starting in 2019. And then Malawi really was the richest data set from an individual level data perspective. There were data available from 2018 to 2022. We've even since received updated data from there, but about 20,000 people in total, about 10,000 in the KPF districts, and in the comparator districts, we had nearly 10,000 people, and we had available data looking at testing, treatment, and select demographics. And I just want to highlight that no research study will ever enroll 20,000 key populations in a country. And it just sort of shows the sort of intense value of better leveraging these data as part of our learning process moving forward. Some quick thoughts on results in my last few minutes. I want to highlight sort of here really the heterogeneity in what we saw. So for example, in Nigeria, there were really these intense increases in testing and case finding from May to June 2020. So from the time this sort of COVID initially hit to these, where we saw these adaptations take place. And for sex workers, we saw a lot more case finding as a result of the work of partners, but less so, for example, for MSM. And for people who inject drugs, we actually saw decreases in HIV testing over that time. And it sort of shows the difference in terms of the ability to rely on clinics as implementation spots for some communities and not other populations. We also saw significant differences in terms of ART initiation, again, with the highest among sex workers and lower so among other communities. But there was over 80% viral suppression data where we had viral load data. I will note biased because if somebody completes a viral load, it means that they're more likely still engaged in treatment. But nonetheless, where viral load data were available, it was over 80%. But there was also trends, like lower viral load suppression among younger people, which I think should concern us. Cisgender women, I should say, were more likely to be viral suppressed than cisgender men. And the viral suppression data were highest among sex workers and clients and lowest among people who inject drugs. From South Africa, we saw initially these moderate declines in service provision for sex workers following COVID-19, but then we saw these rebounds almost back to what it had been in 2019 before COVID hit. And then we saw with the implementation of a number of different strategies using social media, increasing the operational hours, expanded self-testing, really saw improvements in HIV testing and case finding, particularly for sex workers. Another dynamic that I think was really important was around ART initiation and retention for sex workers. And so while there was initial decline sort of throughout mid of 2020 in the context of COVID, using same-day ART initiation, intensified retention services, better tracking of clients that are experiencing treatment interruptions, the partners saw improved ART initiation and retention among sex workers. And finally, from Malawi, there was this real sort of scale-up of this enhanced peer outreach activities and the use of drop-in centers. And there we actually were able to compare against districts where they implemented this against districts where they didn't. And they saw, a 3.6 times increase in the yield using these additional KPIF support. Similarly, even more so for index testing, but it was also really varied by population. It seemed that drop-in centers were most successful for sex workers, less so for MSM, although still successful. So I think some of that heterogeneity gives us insight into how these programs are serving different communities. In terms of the 30-day ART initiation, there was a significant increase with the addition of KPIF in the 30 days after its implementation, and so they saw this sort of rapid improvement in ART initiation, and the strategies that were used was this online quick res system, training of peer outreach workers to really refer clients for refills. On-site ART initiation was one that people had deemed being really important, and the use at DICs, I should say, and then at-home support groups for treatment. So just given I just have a few minutes left, I just want to sort of have some closing thoughts. One, I think, again, like scale-up of KPIF happened in the context of COVID-19, but it meant that these partners really adapted rapidly. When we did this implementation mapping and we spoke to them, the amount of replanning that they did in an incredibly short time, I think, could only be described as I think, heroic. There's also this case that there's a lot of variation in data quality, and I think if we think the future is less of these big multi-million-dollar randomized control trials and more about using routinely collected data, I think collectively we have to improve the quality of these data systems. And so in the absence of that, we find ourselves making a lot of assumptions which may or may not be valid. And then also there are challenges in accessing individual level data. And so, when we're using site level data, we lose that heterogeneity that we would get and that nuance that we would get by really being able to look at individuals in all their variety. But I think overall, KPIF investments really supported equitable, sustainable, and community-driven efforts that I think are central to program design. I think the programmatic innovations and adaptations to the services that happened were happening in the context of structural interventions. And I think we see those as being the underpinning of effective programming. And finally, that there are these increases in service engagement that use novel and tailored strategies. And now that as we sort of emerge out of the pandemic era, there's going to be a real question about which of those we sustain over time, given their impact in different communities. And so there was a tremendous number of implementation partners that really did all of this work, and we're incredibly grateful and thankful to them, not just in terms of how they serve their communities, but also sharing data and participating in this, and obviously a number of community groups, USAID and EpiC and J2 partners. So thank you very much.
Thank you so much, Steph. Okay, while we have all of these presenters up on the stage, we're actually going to open it up for some Q&A with the presenters. So if you have questions for anyone, please go ahead and there are a couple of mics. You can step to the mics. After we have a few minutes of Q&A with this group, we're going to invite our friends and colleagues from MPact and Jinsiango to the stage for a very interesting conversation about what KPIF meant to them. So as people are gathering their questions, I'm actually going to take the first one. And I would love to hear thoughts from anybody who's interested in answering. You know, it seemed like from the presentations that we just heard that KPIF was a success story. It was quite a, you know, lots of positive impact from KPIF supported programming. So I guess my question, and actually Tim, I'll start with you, is should there be a KPIF 2 or some variation on it? And if so, what should it look like?
Sure. So I think there's PEPFAR has our new ambassador. He's been talking quite a bit here. I think there are lots of opportunities as we think about where PEPFAR is moving. I think as we think about the broader context of the HIV epidemic and where we need to move, it's very clear that we need to continue to focus on key populations. We need to continue to work with populations, understanding how to get to the last mile and how to really meet the needs of populations who continue to have high incidence is going to be critical. Whether or not the best vehicle to do that is through in a sort of a similar key population investment fund, I don't know if that's the right way to do it, but I do think that there's lots of room for us to continue to dialogue and figure out how do we best meet the needs of these different populations.
Hallie, you want to comment?
So I think actually what was highlighted today were two of the things that I know need to be part of whatever comes next. The first is a reinvestment in the structural interventions that are so necessary. The ambassador has laid out equity as one of his core pillars. And I know there was a lot of disappointment in the community because the original version of KPIF was announced as something that would really focus on structural interventions. As it got redesigned by USG, it ended up being more integrated into COP and COP processes. I think we really need to revisit the need for, you know, dedicated funding for structural interventions to address inequities and disparities in the KP communities. I think the second thing that I would definitely say is more of the regional technical support that was described here today by both Endosante and IHRI. It was rousing success, community, serving community, and the allyship that's also created as part of that is extremely important in moving programs forward. So maybe just the last thing, I would say one more thing, with a re-emphasis on the policy and the advocacy side as well. There's a lot of work to be done in countries in revisiting existing policies that are disadvantageous to accessing services, to just being in the community, and closer work maybe with our colleagues on democracy and governance, looking at the overall environment and policy environment for key populations, I think will have tremendous downstream effects on the health of key populations.
Anybody else want to comment on that question? No, because we can go to the floor. Okay, let's go here first.
Hi, David Miller reporting for Health HIV. And it's notable that this is the 24th World AIDS Conference, and that nowhere during this meeting are we having any discussion on including new key pops, specifically combat veterans. I'm not talking about United States combat veterans, I'm talking about Ukrainian and Kenyan and Ethiopian and Filipino combat veterans. I'm talking about veterans from LMICs. And we include commercial sex workers because they're at obvious high risk, but that's an occupation. Commercial sex work is an occupation for them, and we've all gone through 30 years have recognized that. When it comes to combat veterans, whether they're in Syria or whether they're in Afghanistan and were our allies during the war there, depending on what side you were on, we don't include them. And this is the 24th World AIDS Conference, and we still don't have one presentation. We have extraordinary risk factors, and I am a combat veteran. And in my unit, we have an extraordinary high risk of HIV. And if you look at West Virginia, which is a third world country and eligible for PEPFAR funding, the rates of HIV are extraordinary. Does anybody think that the rates of HIV in the stands aren't going to be as well? So my question is, with that background preamble, how do we get combat veterans included in the key populations in the investment fund and throughout? Because we're really sick of dying after we come home and survive all that crap over there.
Thank you for your comment and question. Tim, do you want to take that?
Great, thanks for the question. I think one of the things that we continue to learn, and we talk about the HIV epidemic at a global level, and we talk about it at a country level, and we talk about it at a local level. I think the data are really what need to drive decision makings about how do we respond to where the epidemic is. And so I think as we get a better understanding, part of the problem is, how do we get the data to understand where the problems are? How do we pinpoint where incidence continues to be high, or where do we have spikes in incidence and things like that? But I do think that at country levels, we need to continue to get better data and understand where exactly incidence is coming. And it's not a static issue. It changes. We've seen across the past 20, 30 years that incidence does move to different populations. And so really understanding where the data are telling us to go, I think is a key first step.
Thank you. Let's take a question over here, please.
You don't get data if you don't fund the data collection.
Over here, please.
Okay. Hi, Mike Pickles, Imperial College. Thanks to the panel for a really fascinating discussion this evening. I was just asking, and I know you've kind of touched on this a bit just now, again, mentioning kind of trying to understand with more data collection, but specifically, so I used to work on the Avahanj project, which is a key population intervention in India. And one of the key learnings that we had from implementing there was really the necessity of having size estimates of the key populations at a local level. I was wondering, to what extent are you doing this, and is this something that would help you kind of to see the remaining gaps? Because are we seeing all the key populations? Are we accessing them? Because it's great to see the numerators there, but I was wondering really what are the denominators as well? Thank you.
Steph, you want to comment on use of population size estimates?
No, I can comment. I think that maybe what's changed over the last number of years. First, I think with all the challenges that size estimates bring and the sort of lack of attention to sort of the individuals within them, there is a lot more attention in Global Fund programming and PEPFAR programming to denominators and coverage estimates than there was 10 years ago or 15 years ago. So I think that the work of Avahan kind of got embedded into the COP process. And in some ways, with challenges, we were recently in Gisli, I don't know if you want to talk about it, but in Praia, talking about the challenges that has brought. But at the same time, I think it has been embedded into the COP process as well as the sort of global fund development process. So,
if I could just respond, so there's actually a poster by Ollie Stevens that was out earlier today, and he'd been synthesizing data from across Africa, and just looking at that, actually he come across the same point as I do. So I think there's still work to be done, but I totally get your point. Thank you.
Thank you. Let's go over here.
Thank you very much. Can you hear me? Okay, great. So I have 3 questions. I'll try and be very quick. So they're kind of interlinked. The first one is, I thought you guys, just commend you, I think you did excellent work on the KPI program. I thought you had really interesting strategies. And my first question then would be to find out how it will be possible to access the resources, the learnings, the different intel that you gathered in this process, and to sort of learn from that as part of your technical assistance. So that's the first one. The second one is because I am a lawyer from Ghana, and I remember you mentioned that there were some discussions with lawyers from Ghana, et cetera, and in terms of looking at the structural barriers that inhibit key population service delivery, et cetera. And I wanted to know whether the discussion moved beyond just a discussion to actually seeing impact on the ground in terms of what KPIF was able to do, because from the Ghanaian context, which I can speak to, I don't know that I've seen so much, but I'll be grateful if you could share more highlights on that. And the third one is kind of linked to the moderator's question in terms of whether there'll be a KPIF2, and if there is, how interested organizations can access funding. Thank you.
Thanks for your great questions. Maybe we'll start with Nisali.
Can you hear me? Yeah, okay, thank you for your question. On the first one, accessing learnings, for my organization, we are available to have further discussions with you. I can share our different contacts. We can move the discussion forward in terms of not only talking about it, but also sharing whatever documentation we have that could support the different efforts that you currently have in your country. When it comes to lawyers from Ghana, I would like to say that we also need to consider that this is one part of a global effort. The KPIF-supported project was there just to provide, as I said earlier, a platform for discussion. So we had the opportunity to put together lawyers from Ghana, but also lawyers from Mali, to exchange on what their specific experiences are when it comes to addressing human rights violations. And the way we are moving this forward is that we are currently working on a training that we are going to have for parliamentarians that is going to focus on the link between health and violation of human rights. So I would say that that is the way to keep the discussion moving, in making sure that legislators are also sufficiently capacitated to know that there are some dispositions in their current laws that pose a threat when it comes to access to health for everyone. So I would say that that is one of the way that we are making sure that discussion is moving forward and being transformed into concrete actions. Yeah.
Thank you. Did you want to comment on the funding?
Yeah, sure. So in terms of, again, I can't predict the future of whether or not there will be a KPIF2, but I can certainly say that there will be, as we think about where PEPFAR is moving, that there will be a continued focus with key populations, that there's a continued focus on equity, and I think all of these issues will continue to be incredibly important as we're thinking about sort of where we move after epidemic control, as we think about how we really sort of reach the last mile. In terms of how do you get more information, I think some of the best people to reach out to would be the local partners who are already involved or who were involved with KPIF. Certainly reach out to the EpiC project. It's operating in a lot of the countries. And then finally, also if you're in a country that has a USAID mission, we can certainly help facilitate reaching out to our mission staff who have a much better sense of what's happening in individual countries. Thanks.
Thank you. We're going to take one more question here and then move on to the last portion of the session. I do know there are some other people standing with questions, and if we have time, we can maybe get to those at the end in the last bit of Q&A. So last question here.
Thank you. Thank you all. One of the persistent challenges in the pandemic has been a reluctance to shift real power and decision-making to key populations-led groups. I'm wondering especially about structural interventions and how the decision-making was done about what structural interventions to prioritize.
So that's a great question, and I think it's probably going to be addressed to large extent by the next couple of discussants. So why don't we give our presenters here a big round of applause. I'm going to have them move off the stage, and as they are transitioning, I'm going to introduce our last two speakers. So Johnny Tome is originally from Lebanon and is an LGBTQI rights activist. He is a clinical psychology graduate and currently is the Senior Community Mobilization Manager at MPact Global Action on Gay Men's Health and Rights. Welcome. And he is joined by Alessandra Ogeta, who is currently the Deputy Director with Jinsiangu, Kenya, a locally registered Kenyan NGO based in Nairobi that works to increase safe spaces for and enhance the well-being of Kenyan intersex, transgender, and gender nonconforming people. I also want to acknowledge that we were supposed to have two other representatives from KP-led CSOs physically with us in person today. They were denied visas and so are unable to be here with us. But we are going to take advantage of having Johnny and Lexi here, and I'm going to turn it over to you all.
Thank you so much, Rose, and thank you everyone for sticking with us at the end of a day, and it feels like maybe the 11th day of the conference by now. So we're going to try to keep it light and just talk from our experience. I am to start with a little bit about what was our experience as MPact, and then we will move to see how those who were working on the implementation of the program on country level, including a video that we're going to get from those who are not able to join us. To start, as was mentioned before, MPact was supported by FHI 360 to help within the implementation of KPIF in, I believe, 9 countries. And our main role was focusing on technical assistance. But that, before going there, I do want to go back a little bit on something that was not mentioned, which is you know, why KPIF was happening and what did we want. And we were there from the beginning advocating for money specifically for key population that would reach the hands and get implemented by key population, and that would tackle structural intervention. And we've had the question twice why we don't have KPIF 2. And while I do celebrate wholeheartedly all the success, I do believe maybe part of the reason we're not having KPIF 2 is because some of these communities were not happy with how it ended on some of the levels that it ended. And as we saw a lot of data around amazing efforts that were done in increasing access to services and treatment and all of that, that was not why we wanted KPIF. We wanted KPIF for structural interventions. That's why we called for that money. And we wanted it to go to community, all of it, because when we were fighting for KPIF, we were looking that over 60% of communities that are being infected with HIV on a daily basis were receiving 2% of available money in the HIV in middle-income countries, low and middle-income countries. And that just didn't make sense. And we knew that the money needs to go to the hands of key population. We called for KPIF and it was gonna happen, and then it was stalled. And I remember at the AIDS conference in Amsterdam, we were storming into session after session of USAID and PEPFAR people asking them, where is KPIF money, until we did get it. And I think the rush and that confusion that also some of our colleagues talked about, that there was some confusion in some of the places, I think it all started there. I do hope we will have KPIF 2, I really do. I think we could do it right. I think a lot can be learned. And I think we just learned that with a little bit of money, a lot of work has been done, and some of the stuff that we've been trying to do for years and years, we managed to do it once we gave the money and the support for key population on country level. And here I do want to acknowledge all the people that work within this, especially with the support of FHI 360. I personally was supported a lot by Kate. I don't see her here, so please tell her that I send my regards. And finally, to end with what MPact specifically did, we provided to country partners to answer the last question that was asked here. Part of our work and what we worked with FHI 360 on is getting included in the process of reviewing expressions of interest by country organization that wanted to benefit from KPIF money, and doing some sort of a rating based on multiple indicators that we've agreed on would touch on the structural interventions that we were hoping to achieve. And then that was followed, once those were identified, it was followed by a needs assessment specifically around those issues. And that needs assessment led us to identify in each country what is the type of technical assistance that we need to do, and what are the ways that we can make sure that we really work on structural interventions. So some of the main needs that came up that we worked on was definitely around within implementing services to removal of stigma and discrimination in healthcare services, making sure that healthcare providers have the right knowledge and have the right attitude to provide services, and to train law enforcement agents to work with communities from a rights-based approach. But also we did get a lot of needs that are more on a basic level in terms of organizations wanted to know how they can really set up their financial system in order for them to absorb money efficiently and be able to report to donors in a way that will allow them to get future grants. They wanted to know how to, run administration, how to create strategic planning for the whole organization beyond the implementation of the EpiC program itself. So there was a lot of those needs as well that touched more on like the core support and the organizational strengthening that was there, other than the other type of capacity building and working on skills. I was involved in the whole project, but also specifically I was involved on PEPFAR and COP support, and that was one of the areas that I honestly did believe we did make some remarkable change in some places, because any gain that you can get in PEPFAR, especially during the country operational process, for those who have been engaged with it, they know how hard to change anything, and if we did change something, it's one of those things that basically they stay there. So for me, those were the ones that I celebrated the most, and that was done collectively. So it's not an attribution to MPact. It's just a contribution to the work that everyone was doing across the board, including partners within U.S. agencies that were facilitating, and they were connecting us to different people. I'm going to stop here about MPact and the work that we did. And I do want to move and talk with you, Alessandra. But before that, I believe there is a video that. All right, then let's do that. Especially that we want to have a conversation. Some people would have questions. So thank you again, Alessandra. And maybe we would like to start about you letting us a bit more about your work with John Sangu and within the implementation of the EpiC program. And what did it mean to you to have a program like that, and what were, in your mind, the main successes of the work that was done?
Well, thank you so much. Hi, everyone. I'm very happy to be here, obviously, and I think KPF found us at the right and opportune time to really engage in a meaningful manner. Normally, and unfortunately, trans populations are normally the last populations to be included within national strategic plans, right? And when KPIF came, we had just come out from advocating for that inclusion, right? We had done just about everything from being question around size estimates, getting the numbers to form some sort of basis as to why it was important to include trans people within the framework, and to work with trans people for programming. And so when KPIF came and the grant came in, we were best positioned to absorb that role. And some of the activities that we were able to achieve during that time were very clear, and because the objective that we had was we needed to ensure that we had some sort of stronger organization capacity, right? And that is something that KPIF offered. That grant really gave us that opportunity to ensure that we have organizational capacity instruments in place. So we have financial instruments in place to absorb fund, to account more clearly. We have M&E tools to engage more, to report more clearly around all these things. And And I think the importance of working with government. So I think also new partnerships with the in-country government officials and ensuring that we engage in a manner that is streamlined with the entire process. I'm sorry, I'm really nervous and I'm all over the place, but.
No, thank you so much. And this is really, and I think some of these lessons we saw them, and we saw them across the board. And while we are celebrating all the successes, and they were very important, can you tell us a little bit more about some of the challenges that you might have faced, and then we can talk about how we can learn from those.
Well, because we were COVID really was something that was a huge factor that really limited us. We had to come up with interventions that were really geared towards strategic goals that are going to be very impactful to the program. And remember, we had to come up with guidelines to support the implementation of whatever we're doing. So the guidelines were not ready. And so, of course, here is the KPF program that we need to implement. We don't have advocacy manuals and tools that are going to support the program to really implement all these things that we need to do. So we really were waiting for a lot of things to be kind of finalized and be put in place so that we can actively begin this program and ensure that we're implementing it in the right way. So the challenges were not particularly from the KPIF side, but were particularly from our side, because this is a new program, and the new program really had to kind of set up some sort of clear indicators and clear structures, right, before we start implementing. And I think the challenge was, how do we ensure that we implement a successful program, ensuring that we have structural interventions that are already laid, because that's ideally, like I said earlier, the program KPF grant came at a time where we were really starting, and so the conversation were quite rushed. So that's another thing. The conversation had to be rushed, and we had to work extremely hard to ensure that we had all those structural things in place before we started implementing. And so we had to be very clear that the guidelines have been approved, right? We had to ensure that the advocacy manuals have been adopted for trans populations. We had to ensure that the paralegal manuals for the other trans paralegals have been adapted to fit the population that we're going to serve. So we really had to ensure that all these things had to be in place, but of course, the grant was there for that. And like I said, the grant came in at the right time, to say the least, really, because it really solidified whatever we were doing in terms of accelerating or where we wanted the program to get. Yes.
Thank you, Alessandra, for that. And maybe my last question is, if we are to think about, maybe we're giving ideas to USAID, if we are to think about an initiative that would be really specific for key population, or if you want to just think also about your community, and that would be tackling structural barriers, what are the important components in that initiative that you and your community would like to see, that you believe would lead us all to success?
Communities. I think we have to we have to allow communities to lead this process, Not to say that the other processes were not good, but I think, like someone mentioned a few minutes ago, this is 2022. We've been doing this for quite some time. We have experience. We know the technical. We have the technical know-how of how to run a program. I think resources should come directly to the key populations themselves, because we know exactly what we need to do. We have drafted some of these wonderful policies that have ensured that there's inclusion and there's clear pathways of how we are going to come up with interventions and all that. So I think communities should be involved more directly. I think that's an overarching comment that I have to give. I think it's very important to involve communities. And I think designing a program should not be at a level that is far away from communities, right? I think we should be at the table from the beginning. I think contextual analysis is very important. I think thinking that it's going to work in this country because it worked in the other country is a bit myopic, you know? And we need to understand that things are different, you know? I come from a country where trans organizing is doing far much better than other organizing, other KP organizing. And so if you look at that in that global perspective, then we are always going to suffer because globally trans populations are not particularly up there, you know? And so I think it's only fair to kind of see how different programs are working in different countries, and let's not just think that because certain programs are doing wonderfully all over the world, then it's the same all over the world, I think.
Yeah, thank you, Alessandra, so much. And maybe just also to add to that at the end, I think as we are recognizing the importance of working on structural barriers, we do understand that laws and policies are the biggest obstacles you know, in front of communities to not just reach services. And our goal is not just to have people, you know, put pills in their mouth and just move away. We really want to uplift human beings and recognize them fully in their dignity. And we always associate our behaviors with negative outcomes, and we're always looking into all of our behaviors in relation to, you know, to stigma, discrimination, prison, death, disease, and we rarely look at them and associate them with the pleasure, with the community, with the support. And I think building programs and looking into those aspects of, you know, allowing people to live their human life fully, I think these are our goals to the future. And I think a start is to start removing the laws. And when we talk structural barriers, we have to talk them also in-house. And what are our structural barriers? Do we really still want organizations who are getting us money to sign anti-prostitution law? Like, this is just ridiculous. The fact that they cannot call for the right of to achieve their full human potential and live freely in this world. And yeah, we are privileged and lucky because as a US-based organization, we don't have to do that, but all of the partners still need to do that. And so we also need to do some advocacy there, and we need to start. And I know this is on the Congress, so as I recently became an American citizen, I will do my best on my end, but I also invite everyone to use all of your privileges to also remove structural barriers on every level. So thank you so much, Alessandra, and thank you, everyone. And we can now maybe watch the video quickly, and then we can move to questions from the audience. I think we have, what, 5 minutes? Should we go through? I like that. Yeah. So if people have questions, you know where the mics are.
Thank you for giving me the opportunity to speak.
Thank you. We're not going to play the video. Thank you.
Hi, my name is Sonika.
Thank you for giving me the opportunity.
My name is Sonika Francis. I'm the executive director of the Black Sex Worker Collective. And as we previously stated in an earlier session today, sex worker focused is not sex worker led. So what I would like to know is if there is going to be a part 2 of this study, and for part 1 as well, were there any sex workers that were lead researchers on this project? And if not, how do you plan on implementing that for the future?
Thank you so much for your question. I don't think I'm well equipped to answer about the study since we're mainly talking now about like the program implementation itself. I don't know, and I'm not sure if within the work there were any research work that was done.
I'm sorry. This was really in response to the first portion of the study. So if anyone's here from that first half, I would really like to know if there were any sex workers leading, and if not, how do you plan on changing that?
You can use the microphone there. Thank you.
I think it's a really important point. I think the program implementation was sex worker led, where there were community groups and we talked to them and got implementation mapping. There was no additional data collection that was done, no surveys were administered, no data were collected from any people. So all of the implementation and the data was absolutely KP or other community-led. And then, but then we use those analyses in partnership to do kind of what we presented today. But I think it's important in the context of doing an active research project, it's critically important to kind of work together. But it's really important to say, like, no data were collected as part of this. There was not like an ethical review process or anything, because no data were collected in this process. We just used routinely collected data from the community partners.
Thank you. I think.
Sure. So thank you so much. I really appreciate the opportunity to hear from you all. And Lexi, just thinking about Jinsiangu and the work that you all have been doing for so long, that really, even before you did HIV work, right, like centered trans people, intersex people as humans, and thought about the range of needs that you have as a human being. And what I would love to hear from you, because I know that you all made this investment, but Johnny as well, if you want to comment, is how you see the role of mental health services, which I know you use KPF funding to really bolster those. Just how do you see that as part of giving communities opportunities to really take on leadership, et cetera, because they do then have the support to deal with a lot of issues that happen in day-to-day lives for a lot of members of key populations. Thank you.
Thank you, Robin, for that question. Yes. We as Jinsiangu have been doing a lot of mental health work and giving support to our members and advocating for that. And I'm also glad to mention that even as we were prioritizing when we were doing our guidelines for the trans guidelines, under the biomedical intervention, we prioritized mental health, especially for all populations and specifically for the trans population. It's very important that we understand the impact of mental health within our work and within our lived realities. Mental health is particularly something that trans people have to go through. And if we don't talk about it and if we don't recognize it, then it means that we are forgetting a huge component of our program and our intervention. So thank you so much for raising that. And I think, and just to answer you directly, it's something that we have prioritized even under the work that we are doing in Kenya. We have been part of the Mental Health Act, which was just introduced the other day. So we give a lot of information around trans population. There's a lot of studies. Of course, there's the gender analysis studies we did together with FHI back in 2015, and of course, there's the one we did with 9 other African countries on are we doing all right, and all those studies really fed into the mental health bill. So it's very important that we have countries that recognize the importance of that and prioritizing that. And it will also be very nice if KPF2 will prioritize that.
Thank you, Lexi. And I think we have time for one last question. Please go ahead.
Hi, thank you. My name is Tariq. I'm from the Elton John AIDS Foundation. And I had a question around sustainability. So one of the claims in the evaluation was that program achievements were sustainable. So I wanted to understand how that was evaluated, particularly given the lack of structural interventions. And then also just to understand what your recommendations would be for future funding in terms of supporting the sustainability of achievements.
Thank you for your question. And I can probably partly answer that, and maybe if someone from the previous panel wants to kind of answer from their perspective. From our perspective, I think the sustainability part definitely is always related to the capacity building, and one of the things that I mentioned were identified as needs within these organizations is their organizational strengthening itself. And so it's not just about the individuals, because we all know that individuals come and go. And in the past, we've done a lot of training, and we still always do the same one with new generation, and we will keep doing it. It's definitely very important, but it's also important to build a strong base. Also, some of the advocacy that we use, this program allowed us to do some of the advocacy. I gave an example about, a little win at COP where, the government in Cote d'Ivoire is gonna give PrEP directly without asking for different tests before getting PrEP. Like that's some of these guidelines that if we manage to change them, that is gonna have a long-lasting effect. So this is how we understand some of the sustainability that happened with the work that we did. And definitely when you hear Lex talking about the organization, the growth that they did, and not just the reputation of an organization, but also the impact that it has on a community. When you influence people's lives, that's sustainability, right? It's not just about the numbers. I understand and I value the importance of sustaining number of people getting tested, but I'm more invested in the human, and I think that's when we talk about structural interventions. When we influence a change for a human being, that's how we can look at sustainability. But if there are any specific other issues that the previous members of the previous panel would like to mention, please go ahead. And I think that would be the last word of the day.
I'm going to wrap us up then. Can we get one more round of applause for our really great presenters? So, yeah, this was a really great set of presentations and a really lovely conversation that you let us observe. Thank you very much for that. And I want to say, like, we really just scratched the surface in terms of what we did, what we learned, what we achieved through KPIF. But it was nice to take this moment to reflect on some of it and talk about it a little bit. I don't want to try to summarize what we learned, but just a couple of key takeaways from KPIF. I mean, I think we know we have to continue to invest in community-led programming, right? And that includes investing in community-led organizations. And we now know that we can really effectively build the capacity of local partners by leaning on partners that have been working in this space for a very long time. I think, two, we've got to continue, actually we have to do more in investing in structural interventions. It can't be peripheral, it can't be an add-on, it really needs to be deeply embedded into comprehensive HIV programming. And then the third point I want to make is just, anybody that's implementing PEPFAR-supported programming, whether through COP or KPIF, is obviously collecting lots and lots and lots of data. And I think with Steph's presentation, he showed that there's a lot we can learn from those data if we invest in doing more analyses, rigorous analyses of those. So for the scientists in the room, I think there's also a lot more we can do there. So with that, I'll wrap us up, and thank you for staying to the bitter end.